Hello, everyone, and welcome to another episode of Let's Talk Hereditary. Dr. Church, thank you for being with us today. Our topic today is FAP, or Familial Adenomatous Polyposis. We wanted to talk a little bit about the disease and dive in a little bit into some of the details. But just to build up some understanding about it, what is FAP and what does it stand for?
Well, you just said it, Familial Adenomatous Polyposis.
I had to slip an answer somehow.
Yes, give me a clue. So it's a hereditary disease due to a mutation in a key tumor suppressor gene called APC. And when that mutation is inherited in the germline, that is through a spermatocyte or an oocyte, usually at conception, or handed down from a parent, this will produce the mutation in every cell in the patient's body, and it's classically expressed as multiple adenomatous polyps in the large intestine. There are many other extracolonic manifestations, but that's the main threat to life. The most common cause of death in FAP is colorectal cancer.
Just before I go into my next question, I just thought about the word screening and surveillance. We talk a lot about screening colonoscopy, which all the general population do. What does the word surveillance mean?
Surveillance means colonoscopic checking of somebody that's already had something or has something in the colon. So screening means somebody who's completely asymptomatic and, as far as we know, doesn't have a disease. So we're just checking to see if they have the disease. Surveillance applies to people who have had or actually have a disease, and we're looking to see how bad it is, to see if it's come back. So that's the essential difference.
Okay, so talking about FAP, what is our surveillance protocol? What age do we start, and what does it stand for?
Well, before getting into that, let me just summarize our main aim in treating patients with FAP, and that's to prevent them from dying of cancer. In particular, colorectal cancer, because it's the commonest cancer in untreated patients, and it's the commonest cause of death in patients with FAP even now. But other forms of cancer as well. So we don't want them to get cancer, but if they get it, we want to find it when it's curable. So that's our main aim. We don't want anyone to die of cancer with FAP. The second aim, which is close to it, is to make their lives as normal as possible. So we don't immediately jump into surgery. We don't want to be intrusive and do surveillance examinations every 3 months. We want to have them to have a normal life with as low levels of anxiety about cancer and about treatments as we can possibly manage. So our surveillance programs are based around those two principles. So we have to be aggressive enough that we don't miss cancers, but not intrusive enough that we make their lives miserable.
So you just mentioned our mission statement in the Sanford Weiss Center, which is improving quality of life for patients and also preventing mortality from cancer. So really focusing on them, understanding their disease and taking care of them. So when patients come to us with FAP, what are the steps that they have to go through, and what are the appointments or screening protocols that they go through?
Well, patients come to us under two circumstances. So the first circumstance, which affects about 25% of patients with FAP, is that they don't know they have it. Either their family didn't have it, they didn't know they were at risk, and even when we're doing genetic testing in FAP, about 25% of people, they don't have an affected family member, so they don't know they're at risk. So the only way they know they have FAP is the polyps have grown big enough to produce bleeding or diarrhea or abdominal pain, so they're symptomatic. Those patients are often older, and there's a 60% chance they'll already have a cancer in their colon. This is why it's important to get to them as early as possible. So that's the symptomatic group. About a quarter of patients, advanced disease, often have a cancer. The asymptomatic patients are the ones that know that they have FAP or know that it's in their family, so they know they have to get checked. So those patients and those families have often been genetically tested, and all the at-risk relatives have been tested, and they know if they have the mutation or not. If they don't have the mutation, they're free. We will do a routine screening colonoscopy at age 50. If they carry the APC mutation, It means, because this is a 100% penetrance disease, it means if you have the mutation, you're going to get it. So they need to be screened. And we start our screening colonoscopies at puberty, so at age about 10 or 11.
So age 10 or 11, they start screening unless they've had symptoms at an earlier age, then they'll get a colonoscopy based on that.
Yes, as long as we know that they carry the mutation.
So now talking about FAP, are all patients with FAP the same? When you get a patient with FAP, will you treat all of them on the same basis, or you personalize the treatment based on each patient?
The disease is very variable in presentation, and the variations can occur related to where the mutation is in the gene. So what we would refer to as a genotype-phenotype correlation or association, so that patients with the mutation in certain areas of the gene have profuse polyposis. Thousands and thousands of polyps, whereas patients with mutations in other areas in the gene have what we would call attenuated polyposis, which is less than 100 synchronous adenomas. Similarly, the mutation location will determine whether patients are at high risk of desmoid disease and other manifestations of the mutation. In addition, with each family with FAP, they have the same mutation. So you might expect identical disease in everybody in that family. It's not the case. Patients within families can vary in the severity of the polyposis, in the way in which other organs are affected. And so there are other modifying factors that may be gender, for example. Men are affected more strongly than women. So a brother and a sister might be affected differently. Different ways in which they live their lives, so different diets, different physical exercises, and then what we would call modifier genes that we don't really know about yet that would modify the effect of the mutation.
So that raises a very important point, in my opinion, that when you see those patients being treated in a normal center, or the person that does not understand the disease will put you at a standardized outcome, which is surgery or not. But we have to understand how the disease evolves and how different it is between patients. My next question to you is, we talked about surgery, we talked about screening, but what are the indications of surgery in patients with FAP?
Well, again, getting back to our primary aim, the indication for surgery is to stop them getting cancer, or if they've already got it, to cure it. And then the second aim is to do it in the least intrusive way possible. So in a patient with mild polyposis, for example, we may delay surgery. We may rely on colonoscopy and endoscopic polypectomy to keep them safe. But then if, as endoscopists, we feel that we can't keep them safe, then we go to surgery. We have choices of surgery, so we will choose the most appropriate one based on the number and the size and the risk of the polyps that they have.
So that's one concept of surgery, which is polyps burden. We might just do colonoscopies and follow them or operate on them. But also sometimes we see them for the first time and they have cancer, or they have what we call a polyp burden that we cannot control, so they end up in the operating room. My next question too is, we mentioned FAP is a syndrome, and sometimes there's something we call extracolonic manifestations that could affect our decision making when we're saying this patient needs surgery and what type of surgery do they have. Do you mind elaborating a little bit?
Sure. So there is a spectrum of extracolonic manifestations in patients with FAP. And if we think about causes of death, after colorectal cancer, the next most common colorectal cause of death is duodenal cancer. And these patients get polyps in the stomach, and they can be malignant. And in the duodenum, almost all of them will get duodenal polyps, and about 10% will get a cancer. So that's an important organ to keep under surveillance. The third most common and the third most serious extracolonic manifestation are desmoid tumors, or desmoid disease, if you like. There are many other manifestations that are not quite as common, but important ones are thyroid cancer. So we screen patients for thyroid cancer with FAP. A lot of skin bumps and lumps, and then uncommon cancers tucked away in the body, such as adrenal adenomas, adrenal cancer sometimes, small bowel adenomas and small bowel cancers, and biliary tract disease.
You mentioned the word desmoid. What is a desmoid tumor?
A desmoid tumor is a tumor of fibrous tissue or scar tissue, if you like. So it's not from the lining of the bowel or the lining of an organ. It's completely different. It's scar tissue, so it's a mesenchymal, if you like, type tumor. It's related to sarcomas, but it's not malignant, so it doesn't spread. What it does is interfere with the organs around it. It's like it sticks itself to the organs around it. It can displace them, it can obstruct them, it can distort them. Half of the patients in FAP with desmoid disease get it inside their tummy as a result of surgery, or surgery stimulates it. About a half of them get it in the muscles of the abdominal wall, also because of surgery. And about 5% get these desmoid tumors in various parts of the body.
So just to get a little bit technical when talking about desmoids, how do you think desmoids happen inside? Most of the time we see them in the mesentery and they affect our operations. So what is your theory about desmoids?
Well, like every other cell in the body, fibroblasts in a patient with FAP are born with one mutated allele. So in order to stimulate abnormal growth in the fibroblasts, you should lose that second allele. So the question is, what causes that second allele to be lost, or what stimulates a fibroblast with a problem with FAP to grow abnormally? And it seems to be, in most cases, that surgery does it. It's not surprising because fibroblasts create scar tissue. Surgery creates scar tissue. And it seems that if you put these fibroblasts under tension by stitching them, by distorting the bowel, by pulling the bowel, by sewing the bowel, that you're going to stimulate growth, and in the patients that are prone to it, you'll get desmoid disease.
When you see patients with desmoids, how does that affect your decision-making when you're thinking about surgery?
Well, if I see a patient with a desmoid, I'm really a bit late to the party because the risk of desmoids should really influence your surgical strategy. And so with every patient with FAP, I'm interested in what the family history is, because a family history of desmoids is a very strong risk factor for the patient sitting in front of you to develop desmoids as well. So that means that if I operate on that patient, there's a fairly high chance they're going to get desmoid disease. It will vary with the type of operation and vary with the age at which the operation is done and the gender of the patient. So I can make decisions about when I'm going to operate and what sort of operation I'm going to do based on the desmoid risk of the patient.
Dr. Church, thank you for being with us today. Thank you everyone for tuning in today. I'm your host, Mohammed Abbas. Again, if you have any questions or any concerns or any ideas, direct message me or find me on social media or call us at the Jagelman Registry at the Sanford Weiss Center at Cleveland Clinic. Thank you.